Hello, hi, this is Dr. Michael Watson from Arizona Jaw Surgery, here to talk a little bit about TMJ total joint replacement. Again, a fairly common procedure for us in a practice that's limited to TMJ and jaw surgery. I want to share a little bit of our experience and knowledge with this. Again, a brief overview. For more information, go to our website, azjawsurgery.com. Interested, give us a call for a virtual or in-person consultation. We see people from all over the country and others for this condition, and happy to lend our area of expertise to you if needed. So what is TMJ total joint replacement? And on its most basic premise, it's just a procedure that takes a diseased TMJ and replaces it with a prosthetic, which is, for again a crude understanding, metal and plastic, just like any other replacement joint in your body, a knee, a hip, shoulder, etc. We typically talk about end stage TMJ disease when we're talking about total joint replacement, meaning a disease of the TMJ that's run its course to a point where it's at the end and like nothing further can be done. Alternative options are very limited. It's so destroyed or pathologic that it just needs to be replaced with artificial tissue, or again, as an alternative, autologous tissue, if possible. Um, Often these patients have been in treatment for typically numerous years. Other things haven't worked, as I said before, and they've just kind of run its course, and we need to have a more final solution. Things that tend to come along with this are malocclusion, facial changes, sometimes obstructive sleep apnea due to the degradation of the mandibular condyles, which causes the mandible to recede posteriorly and close off the airway. Well, how do we do it? It's typically two incisions on the skin. We show them here, and I'll move my screen here a little bit better so we can see down here. And one is within kind of the crease of the ear, and there's different variations and positions of these incisions that are somewhat surgeon and sometimes patient specific. Typically for me, I try to hide this incision as much as I can posteriorly. So if you see without me pulling the skin forward, the only aspect of the incision you see is right here. And even that is within the crease of the ear. I always hesitate to show kind of 1 week or early images, but this is immediately after surgery. So patient's still asleep on the operating room table. And you can see this is really the only aspect of the incision that's seen. And what's important to know is the hair has been shaved. So these are typically female predominant procedures. They do happen in males, but does have a high female predilection. So with a full kind of conglomerate of hair and anything that hangs down, this is very well hidden, as are these neck incisions or retromandibular incisions. Once we've gained access to the joints, then we remove the diseased tissue. So the mandibular condyle, any soft tissue, any disc remnants, any muscle attachments that are there in order to place the prosthesis, which has two components we'll show you next, one in the ramus and one of the mandible and one in the fossa. And then typically we take some abdominal fat from what we use as a vertical incision within the belly button, so it's never even perceptible. Pack some fat around it, the prosthesis. And then we also do other surgical procedures when indicated. So if you have a malocclusion or a bad bite, facial changes, airway issues, then oftentimes these are done with Lefort 1 osteotomies, which is surgery of the upper jaw to help move that and form it to form a better position. And then chin surgery or genioplasty is often done because with regression of the mandible, sometimes the chin itself recedes, and for aesthetic purposes, having a advancement of the chin can be beneficial. Again, the two components. This is what we call the fossa component. This metal framework goes on the skull base or the mandibular fossa, and then it's screwed into place. Plastic component, you don't want metal on metal. That causes all sorts of problems. So the metal component that's down here on the mandible has this condyle component that then sits in the fossa component, and this is what allows movement within this cup, essentially. So how's the recovery? This is a very important question. And again, I'm going to go back to the incisions just to show you. Again, I always am a little bit hesitant to show these, but I give it a little bit of context and say this is at 1 week. So at 1 week after, this is about as, it's never going to look worse than this. It's only going to get better. Again, the hair were down, it would cover this. We're looking at this with the intent of examining the scar, meaning we're looking at it from the side and even posteriorly. So you see here, the only portion of the scar that's even visible is right here. And this is at 1 week. A month from now, this is going to be nearly imperceptible. And then as it ages more, just going to be non-visible. Important thing we often ignore, but is worth mentioning, is we don't typically look at people from the side. I'm looking at you at the camera, you're looking at me, we're face to face. We're not looking at your ear from the side. When you're talking to people, meeting people, engaging with people, it's from a frontal view. So these incisions, even behind the mandible or in the ear, are mostly imperceptible. You almost have to be looking for them to find them. And then with females, again, longer hair, typically earrings, makeup, other things, very, very, very minimally perceptible, if at all, as they heal and mature. For the recovery itself, it is somewhat patient and procedures specific. What else did we do? Did we end up doing other jaw surgery? Did we have to do genioplasty? Did we do other things that might affect how you would recover? Age, patient specific, other factors, other diseases, conditions, comorbidities come into play with this. And then people just respond differently. Some people have been in pain for years and they're still going to have some pain. Some people are not. But there's some high degree of variability, but we typically will want you to say 3 to 4 weeks off of your life or a month. And that also is dependent on what you do in your life. Do you work remote at home, at a desk, at a computer? Are you face to face? Are you traveling? Are you doing physically laborious things? Do you teach kindergartners? Do you have 6 kids that you have to take care of? Do you have any support? Do you have family, friends, other resources who can help support you during some of your recovery that might dictate how long you need to make adjustments in your life for this procedure? Always over prepare. In life in general, it's easier to ask for more time off or take more time off and then come back sooner than the opposite. So just over plan, over prepare in that regard. Also, you have to allot time for physical therapy. Doing this procedure without physical therapy is going to be useless. Now, that doesn't mean you have to be physically going to a physical therapist or doing that frequently. But if you're not doing the exercises, stretches, using the things that we will give you to help with your mouth opening, it's basically doing this for no reason, and you're not going to get better. And then generally, another thing to keep in mind that we always want to emphasize, because it doesn't do any good to sugarcoat things or mislead you, is this is a rough first week. First week after this surgery is just not pleasant. Again, that helps us prepare and plan. We have measures in place. We do this all the time to where we can help with all of these things, but no way around just kind of having a rough first week. And then it just seemingly each day gets a little bit better. Again, there's patient variability to this. Some people who've had this would say, actually, my second week maybe was worse. Just have to keep all these things in mind. So who do we do this for? Who is a candidate for this procedure? We talked about end-stage TMJ disease multiple times, but essentially what we mean is if you have severe osteoarthritis, so your joints have degraded to the point where there's bone on bone and it's minimal movement, minimal functionality, and it's painful. You can have benign TMJ tumors. Malignant TMJ tumors are exceedingly rare, but benign tumors are rare as well, but can happen. You could have systemic arthritic conditions, rheumatoid arthritis, lupus arthritis, psoriatic arthritis, and others that can degrade the joints to the point where they're no longer functional and require replacement. Trauma, injuries to the condyles, other things that can cause problems can lead to a need for this. And then there are, syndromic conditions that have altered anatomy of the TMJs where either initially or over time they need to be replaced with artificial joints. And then sometimes a little bit less easy to understand or explain are patients who have TMJ disorders but also have other conditions that need to be addressed. So if you have a bad bite or malocclusion that maybe we would normally just do traditional orthognathic jaw surgery for, but you have TMJ disease, well, now we run a risk of reactivating, worsening, causing problems with your TMJ disease by putting you through orthodontics and orthognathic surgery. So we're worried about the stability of that. And essentially what we mean is, what if we put you through all of that and it causes your TMJs to worsen and then you develop malocclusion again, and now we're doing joint replacement and we've now put you through both procedures, whereas maybe doing joint replacement as an alternative initially would have been a more definitive solution. And that gets a little bit tricky sometimes. If you have facial asymmetries, obstructive sleep apnea, and you don't really tolerate CPAP, other alternatives aren't good options for you. Again, sometimes when that comes along with TMJ disease, we do this. We wouldn't just do that if you didn't have TMJ disease and those conditions. But when you have all of them, sometimes that leads us to want to do that. So a common question we get, we talked about the scarring and incisions. That's a common thing that we get questions about. So too is a question about how long these prostheses will last. And if you talk to some quote unquote TMJ experts, you can get a bunch of different answers here. And something that I encounter in our practice a lot of times is patients will come and say their TMJ specialist or someone told them these prostheses only last 5 to 10 years. And that's simply not completely accurate. With this paper that was published over 10 years, or roughly 10 years ago, there was over 20 years of data following patients from when these were first implemented in the early 90s by Dr. Wolford and Dr. Mercuri, that they were putting these in, and the ones that the patients that they can follow up for an extended period of time were not rampantly taking these things out. So essentially, the data we have is that these have been somewhat holding up indefinitely, up to about 30 years or a little bit more now. Now, to be clear, you could have one of these placed and it might wear out in 10 years, and then your cousin could have one and it might wear out in 45 years. There is variability, but what we know from a conceptual idea is these prostheses are not just faltering after a few years or anything like that. If there's not usually some kind of reason why they're exposed to abnormal or excessive forces, they tend to be holding up for 30 plus years. So depending on the age when this would be placed, it might last you the rest of your life. But as a general kind of way of mentally preparing patients, we generally just say, hey, you should be mentally, physically, financially, spiritually, psychosocially prepared that at some point in your life, this is going to have to be replaced. And if not, great. We've over-prepared, over-planned again, and we don't have to. So again, that's kind of a brief synopsis of TMJ total joint replacement, a very common procedure in our office. Again, head over to our website if you want some more detailed information. This is a procedure or something you want to be evaluated for, always reach out to us. We, again, will be happy to meet you in person or via telehealth virtually to discuss your condition if need be. And have a good rest of your day. Thanks.